Resection or transplantation of long tendon of biceps. The long tendon of the biceps is resected or transplanted. The long head of the biceps tendon is an important stabilizer of the humeral head. When the proximal end of the tendon is detached from the glenoid, it is rolled or knotted, sutured, and inserted through a keyhole-shaped opening in the cortex of the humerus in the floor of the bicipital groove. This is performed through a longitudinal incision at the anterior aspect of the shoulder. Once proper fixation is obtained, the incision is closed and the arm is supported in a sling. Active elbow flexion and shoulder elevation are limited until proper fixation and healing are complete. Wedge resection or bisection of ovary, unilateral or bilateral. Through a small abdominal incision just above the pubic hairline, the physician takes a pie-shaped section or half of one or both of the ovaries to reduce the size and repairs each ovary with sutures. Resection of palate or extensive resection of lesion. The physician resects the palate or area of a lesion. The physician excises the lesion and any adjacent tissue where the lesion may have spread. The surgical wound is repaired by intermediate or complex closure, adjacent tissue transfer, or graft. Resection temporal bone, external approach. The physician elevates the auricle with a superior flap. If the auricle and surrounding skin is involved, a wide excision of the skin and subcutaneous tissues is performed. The sternocleidomastoid muscle is separated from the mastoid tip, exposing the internal jugular vein. The seventh nerve is sacrificed. The zygomatic arch is divided. The middle fossa dura is exposed and elevated from the temporal bone. The head of the mandible is removed to expose the internal carotid artery. With a drill and chisel, the carotid canal is opened. The sigmoid sinus is skeletonized and a chisel is used to make the final bony cuts through the medial temporal bone. Hemostasis is obtained with cautery and packing. A paroidectomy and/or neck dissection may also be required. A separately reportable reconstructive procedure may be performed at this time. Otherwise, the incisions are repaired with a layered closure. Resection lip, more than 1/4, without reconstruction. The physician performs a lip resection of more than 1/4 without reconstruction. An incision may be made through the midline of the lip and extended over the portion of the lip to be removed. The tumor and surrounding tissues are removed. The oral cavity is closed primarily, and the lip and surrounding structures are closed with layered sutures. Resection of ribs, extraplural, all stages. The physician resects a rib, without entering the chest cavity. The surgeon makes an incision in the skin overlying the rib to be removed and carries that incision through the tissues down to the rib. The tissues are dissected away from the rib, taking care not to puncture through the pleural membrane on the inside surface of the rib. This avoids the egress of air into the chest cavity. With the tissue removed from the surface of the rib is cut at 2 places and the intervening section removed. The resulting defect may be covered by the use of muscle flaps grafted to the area. The remaining tissues and skin are closed by suturing in layers. Resection or incision of subvalvular tissue for discrete subvalvular aortic stenosis. Cardiopulmonary bypass is initiated. The aorta is opened and the left ventricular outflow tract is assessed below the valve. There is usually a clearly definable ring or shelf below the valve. This is taken off with a tool designed for the purpose. Usually, the left ventricular septal muscle is thickened. A trough of muscle tissue is cut out of the left ventricular septal muscle. The aorta is closed. Cardiopulmonary bypass is discontinued when heart function returns. Resection, initial, of ovarian, tubal, or primary peritoneal malignancy with bilateral salpingo-oophorectomy and omentectomy. With total abdominal hysterectomy, pelvic and limited para-aortic lymphadenectomy. With radical dissection for debulking, i.e., radical excision or destruction, intra-abdominal or retroperitoneal tumors. The physician performs the initial resection of an ovarian, tubal, or primary peritoneal malignancy. Through a full abdominal incision, the physician removes both tubes, both ovaries, and the omentum, which is a membrane of lymph nodes, blood vessels, and fat that forms a protective layer extending from the stomach to the transverse colon. The abdominal incision is closed with layered sutures. The physician also removes the uterus, the pelvic lymph nodes, and a portion of the lymph nodes surrounding the lower aorta. The physician also reduces the size of a tumor that has grown large enough to cause discomfort or problems. Due to the size and location, it may not be possible to remove the tumor. Resection, tumor debulking, of recurrent ovarian, tubal, primary peritoneal, uterine malignancy, intra-abdominal, retroperitoneal tumors, with omentectomy, if performed. With pelvic lymphadenectomy and limited para-aortic lymphadenectomy. Through a full abdominal incision extending from just above the pubic hairline to the rib cage, the physician explores the abdomen, pelvis, and viscera. In addition to debulking recurrent malignancy, the physician releases intestinal adhesions or excises all OR portions of the omentum, ovaries, or fallopian tubes. The physician may remove all visible tumors or only reduce their size, depending on the nature of the malignancy and the structures involved. The abdominal incision is closed with layered sutures. Report 58,958 when pelvic and para-aortic lymph nodes are also removed. Resection of external cardiac tumor. Cardiopulmonary bypass is only required if a significant portion of the heart or major vessel must be removed with the tumor to get a margin of normal tissue around the tumor. The tumor and surrounding normal tissue are removed. Defects created in the heart, coronary arteries, or major vessels are repaired. Resection or debridement of pancreas and peripancreatic tissue for acute necrotizing pancreatitis. The physician performs resection and debridement of the pancreas for necrotizing pancreatitis. The physician makes an abdominal incision. The pancreas is exposed and necrotic areas of the pancreas and peripancreatic tissue are debrided. Drains are usually placed around the pancreas. The incision is closed. Resection of lateral pharyngeal wall or pyriform sinus, direct closure by advancement of lateral and posterior pharyngeal walls. The physician removes the affected portion of the pharyngeal wall or pyriform sinus. The physician makes a vertical incision and retracts the strap muscles. The mucosa of the upper pyriform sinus and the affected portion of the pharynx are excised. The lateral and posterior pharyngeal walls are reproximate and closed with sutures. The incision is sutured in layers. Resection of pharyngeal wall requiring closure with myocutaneous or fasciocutaneous flap or free muscle, skin, or facial flap with microvascular anastomosis. Myocutaneous flap reconstruction of the pharyngeal area is achieved using the pectoralis major muscle and its overlying skin. The flap is rotated and inserted through a previously created tunnel between the clavicle and overlying skin and sutured into place to reconstruct the pharynx. The incision is sutured in layers. Resection of scrotum. The physician removes excessive or diseased scrotal skin by excision. The extent of the procedure is dependent upon the disease process and the degree of involvement. The physician makes incisions in the scrotal skin, taking care to avoid injury to the underlying scrotal contents. In the simple case, the excess skin is removed and the defects closed in layers by suturing. In the more involved cases, the testes and spermatic cords must be mobilized and removed from the scrotum and swung out of the way by making incisions in the inguinal areas. The affected scrotal skin is excised and the testes and cord structures return to their anatomic positions. If not enough scrotal skin remains, flaps of skin are raised from the adjacent thighs and rotated to cover the testes. These grafts or flaps are separately reported. Rubber drains may be left in the scrotum and the operative site closed in layers by suturing. Resection of mediastinal cyst. The physician makes an incision from in front of the axilla just below the nipple line. The incision extends below the tip of the shoulder blade and ascends to halfway between the spinal column and the shoulder blade. The physician exposes the rib cage, retracting muscles. A rib spreader is used to ease access to the thoracic cavity. The cyst is located and removed. The rib spreader is removed, and the wound is closed with sutures or staples. Resection of mediastinal tumor. The physician makes an incision from in front of the axilla just below the nipple line. The incision extends below the tip of the shoulder blade and ascends to halfway between the spinal column and the shoulder blade. The physician exposes the rib cage by cutting through the muscles. The chest cavity is entered between the ribs by using a rib spreader. The tumor is located and dissected from the surrounding tissue. The wound is closed using sutures or staples. Resection of pericardial cyst or tumor. The physician gains access to the pericardium through an incision through the sternum, median sternotomy, or the chest wall, lateral thoracotomy. The physician places cardiopulmonary bypass catheters, usually through incisions in the right atrial appendage and aorta or femoral artery. The physician stops the heart by infusing cardioplegia solution into the coronary circulation. The physician cuts away the pericardial cyst or tumor while the heart is still. The physician takes the patient off cardiopulmonary bypass, closes the surgical incisions and dresses the sternal or chest wall wound. The physician may leave chest tubes and / or a mediastinal drainage tube in place following the procedure. Resection, diaphragm, with simple repair, e.g., primary suture. With complex repair, e.g., prosthetic material, local muscle flap. The surgeon removes all or part of the diaphragm, the large muscle separating the chest and abdominal cavities. The patient is taken to the operating room, the abdomen and / or chest are surgically opened, and the operation is performed. This code involves a simple repair using sutures. A complex repair using muscle or synthetic material for patching some of the area. Corneal wedge resection for correction of surgically induced astigmatism. In the corneal wedge resection, a wedge is cut from the cornea and the edge is sutured. The resulting change in the corneal curvature alters the refractive properties of the cornea to correct the pre-existing refractive error. The speculum is removed. Antibiotic ointment and a pressure patch may be applied. Submucous resection inferior turbinate, partial or complete, any method. The physician removes a part of or all of the inferior turbinate bone through a submucous incision. The physician places vasoconstrictive drugs on the turbinate to shrink the blood vessels. A full-thickness incision is made over the anterior-inferior surface of the turbinate and continued deep to bone. The physician lifts the mucoperiosteum with an elevator to expose the bony turbinate. A chisel or forceps is used to remove portions of the bony turbinate. Electrocautery may control bleeding. The turbinate mucosa is closed in a single layer.